themselves.
Deputy Jonathan Renniff, the Vice Chair of the panel.
Deputy Philip Bellich, member of the panel.
And if you could introduce yourself and your officers, please.
I'm Deputy Lyndsay Feltham and I'm the Minister for Social Security.
Paul McManus, I'm a pharmacist. I provide professional advice to the Minister.
And we have, oh, sorry.
Suda Howell, I'm an Associate Director in the Cabinet Office.
Lovely, thank you for coming today. And we have apologies from Deputy Lucy Stevenson, who couldn't be with us today. Okay, so just to give some background on the review, and Minister, we have exchanged some letters with you and we're grateful for your engagement thus far. The review was undertaken by the panel following concerns that have been raised by members of the public and evidence that came out at previous quarterly public hearings about the medication shortages and various issues around that. We're aware that there are various issues around the medications that some of people have raised in our submission, so we're hoping maybe to question you about some of those issues and to see what your perspective is on those. And Mr. McManus, I wonder if you could just give us a bit of an introduction yourself in more detail as to what your role is and what you do and who you represent before we get into the questions.
Yes, certainly. So I'm a registered pharmacist. I'm contracted to provide professional advice and support to the Minister and to Social Security, particularly around the use of medicines in the community, funded through the Health Insurance Fund. And that involves a range of activities around analysis of prescription data for primary care, working with community pharmacists around dispensing medicines and quality framework. So there's a whole range of kind of support and information that goes on around prescribing in primary care.
Okay, thank you. So you're contracted to advise the Minister, and how long have you been in this role for?
About 12 years.
Okay. That's
On and off.
Yeah, okay. Does anyone want to ask Paul any general questions about his role? No? Okay, thank you. Thank you. So we're going to start with some questions about the Pharmaceutical Benefit Advisory Committee. We note, Minister, from your letter dated the 3rd of September that ADHD medication is not included at this time within the prescribed list of pharmaceutical preparations, which I think means that GPs can't prescribe it, but it has to be a hospital consultant. Is that correct?
It means that it's not funded via the Health Insurance Fund and not on the prescribed list for GPs to prescribe, yes.
Okay, thank you for confirming that. And I think we're aware that ADHD medication has been considered for inclusion in the past. Is that correct?
Yes, we've got application both from the adult psychiatrist, Dr. Muller Sedgwick, and the Children's and Adolescent Mental Health Specialist, Dr. Catherine Keep. They're currently kind of in process.
Okay, thank you. And the reasons for those medications not currently being on the approved list, was it because of the shortages? Is that the main reason that they're not?
At the last meeting of the PBSA, the medicines were considered, and generally the committee was supportive of the medicines going onto the prescribed list. But yes, there were concerns expressed about at this time around the shortages of a number of medicines that are used in the treatment of ADHD, and it was felt that because of those shortages, it would put the arrangements, what we call shared care arrangements, it would make them difficult to enact, because if patients had to chop and change medicines because of those shortages, it would mean them having to go back to the specialist if there was a change in their medicine needed.
Okay, and could you list all of the reasons as to why those medications aren't on the list, so shortages being one of them, and are there any others?
At the moment in time, the shortages was the main concern. I think there was, in general, there was concern, not concern, but a need to understand the whole pathway around. It's not simply a case of asking GPs to write on the bottom of a prescription to sign these. It's about how do we make primary care part of the overall management of patients with ADHD, not simply about who's going to sign the prescription.
Yeah.
And so there was uncertainty in PBS here around how that would all work and how that would all fit together in the pathway for patients.
Yeah, that was mentioned, I think.
Does the insurance fund afford to cope with ADHD prescriptions?
I'm not sure I'm the right person to say whether it could afford it. Certainly it would be quite a substantial additional income. We estimate, based on the estimated number of patients, about 1,500 patients, and the average cost per year for each treatment, which is about £550 a year. So we're talking in excess of £800,000. To put that in context, we currently spend just over 17 million a year on prescription medicines in the community under the HIF. And to put that 800,000 in context, that's more than we spend on treating infections, on antibiotics and things. So it's quite a substantial chunk of money.
Go on.
Can I ask, Minister, what view, if any, you, excuse me, what view, if any, you have about the desirability or otherwise of having ADHD medications covered?
Of course, I mean, I, like many other people, have been following this story before I was in this particular role, and I remember reading about it in the media and thinking to myself, that would surely be the most simple, straightforward answer to a lot of the issues that we know people in the community are facing. So I was of the view, surely that's what appears to be an easy fix. However, then coming into this role and speaking with Paul and the chair of the Pharmaceutical Advisory Board, it became clear that there were multifaceted and layers of complexity around taking that decision. And I was quite keen to ensure, and I asked, in fact, for the board to provide detailed reasons, because I knew that this is actually a matter of great public concern and interest. And when I did receive the advice last time around not putting these drugs on the prescribed list, I was satisfied that the board had given due consideration to all of those complexities, because of course we all want to be in a place where we can resolve the issues, and resolving the current issues. And actually I find that this scrutiny, this particular review is actually incredibly helpful, because it does draw out from other perspectives as well the issues that we're dealing with, and also how we need to work together right the way across government, because we've got three ministers involved here. And I think that we are all committed to finding a way that we can resolve the issues. It was just that there are other things that are currently outside of our control, which means that it's not appropriate at this point in time to add it to the list.
What do you see as the main things that are outside of your control?
So, of course, the availability of the drugs themselves is the main thing that's outside of us as an island and outside of the control of us within our community. Obviously, then we need to look at who then the shared care arrangements as well. And I know that my team and the health team are working incredibly hard to look at those how shared care arrangements may be put into place. Also opportunities for others that aren't necessarily GPs to be able to, so prescribing pharmacists, for example. So there's all sorts of different cogs going on within different wheels, I think, at the moment. And it is around getting everybody to work together. I think people do want to resolve this issue. We know how critical it is for a number of islanders.
Yeah, and that's exactly why we've picked it up as an issue. And I think we definitely agree in terms of your observation that it's not a simple and straightforward matter. So that's something I think bears out in the submissions that we've received and the evidence we've examined. In terms of the shortages, now what you said is that it's something globally that we don't have any control over. In terms of monitoring it, how is that being monitored, and what kind of information do you get about where the drugs are coming from and how much of each drug you can access? And are there different places that we can go to get the drugs, etc.? Like, how does that work?
That's quite a technical question. I'm not sure whether Paul would be the right person to answer that, or whether it would actually be a colleague in health.
I can answer it in terms of from the community perspective. So all of the community pharmacists in Jersey obtain their medicines through UK-based wholesalers and manufacturers. They face the same challenges in obtaining supplies as they do in the UK and are affected by shortages. It is an improving picture, and at the minute, most medicines for ADHD are now back in adequate supply. There's a handful that still there's some problems with. Mm-hmm. We monitor that weekly. There are specialist sources of information in the UK, particularly the Specialist Pharmacist Service based in the UK, which publishes updated information every week around medicines availability.
Is that publicly available information?
Yeah, so it's...
Could you send that to the panel?
Yes, certainly. There are other subscription-based trackers that GPs have access to, but also we take kind of soft intelligence from local community pharmacists about what their experience is. Yeah. Because what we find is that different pharmacies have different sources of supplies, and some are able to obtain limited supplies for their patients, and kind of word spreads then that such and such a pharmacist has got supplies in, but actually they've got enough for their patients, but wouldn't be able to accept any other patients.
I'm just interested, Minister, Mr McManus has said that there's an improving situation. At what point, just coming back to my original question, would you feel comfortable with putting with this as being a potential solution to add them to the list? Or do you think there are other factors other than availability that mean you will not feel like you want to go down this route of adding ADHD medicines to the prescribed list?
I think what would make me feel confident is the advice of the Prescribing Advisory Board. I get good advice from that board. As Paul said, there are current applications in, and the board themselves did say in the last advice to me that in principle they are supportive. Mm-hmm. So I don't see them as being a blocker. I see it that I will look to the advice that I'm being given by experts in that area. It would be foolhardy for me as a minister to think that I could make that decision without the expert advice.
But it would not be, for example, compromise to Deputy Balash's point about the cost, because clearly it is a significant cost. You would not regard that as a blocker were the other issues to be resolved.
I wouldn't regard that as a blocker per se. I mean, we get other advice all of the time, which is saving us money around different drugs to use and things like that as well. But the cost wasn't something that came through within the advice. Of course, we always need to be cognizant of the effect of the HIF, and I need to work together with the Health Minister to make sure that we have a health service that functions as one and delivers the right care and the right pharmaceuticals as well to the community as a whole.
Yeah, and in terms of the cost, from some of the evidence that we've gathered, it's our understanding that there has already been an increase of people being diagnosed with this condition, and there's likely to be further increases. What kind of costs could the HIF absorb in terms of medications for this condition?
I would need to go back to...
There's a point about, so this is a medicine that's currently prescribed in the hospital, and Paul's probably better to do this than I can, but I'll introduce the subject, which is that hospitals will buy drugs at a lower cost than community pharmacies. Okay. And although the shortage situation is getting better now, if you're in a shortage situation, you're better going through one central provider rather than having lots of 30 separate people around the island doing it. But Paul, perhaps if you could just describe a little bit about the cost differential, so in terms of how much does it cost Jersey to have ADHD medication, to cost a certain amount of money to go to the hospital, It costs a different amount of money when it's available in the. It's not to say you shouldn't put it in community pharmacy, absolutely, but you just need to be. That needs to be one of the things you take into account when you're making that decision.
Thank you.
So there's about a 30% cost difference between the price of medicines in the community and what, on average, you would spend on them, on ADHD medicines we're talking about, on what the cost of them would be in the hospital. Because of the kind of contract pricing that the hospital's able to use.
And so in terms of if that was the route that government decided to go down in increasing capacity within the hospital for seeing patients, I know that there's been already some, that's already happened with nurse prescribers, and I know it's slightly outside of your ministerial responsibilities, but in terms of nurse prescribers being offered training to issue repeat prescriptions within the hospital, can you give your views on that and whether that would help?
I think that would be a question for the health minister and his team, but I think that goes to the point as well around us having a single functioning kind of health service both out in the community and then within the hospital, because the points that Sue made about balancing the costs as well, and you know, where we're getting the pharmaceuticals from, we need to see that as a whole, and also check that people have got the right pathways in place, so the right care pathways.
Yeah.
So this is an incredibly complex piece of work.
So wouldn't that be part of that care pathway, that nurse prescribers could be part of that? Wouldn't that be part of that solution in changing the care pathway?
Nurse prescribers is just one of your options. So you could have nurse prescribers today. They can prescribe against the HIF in an appropriate clinical setting.
Yeah.
So that may or may not be appropriate, because we talked about shared care agreements need to be kind of firmly in place. So you wouldn't do that with nurses before you've done it with the GPs, for example, yeah? You could also have the nurse prescriber in the hospital, again within an appropriate clinical setting. So you can have it in either situation. It's an extra string to your bow, if you like, of a health service these days, that there are more types of people who can prescribe both. And Mr. Viv mentioned before about pharmacists and nurses are able to get qualifications to do prescribing within a specific kind of area of practice, yeah?
Okay, thank you. And is that something that the advisory committee would give a view on, that kind of thing?
Not necessarily. I think the PBSE tends to look at an application in the terms of, is this medicine safe, effective, is it cost effective, is it good use of public money, how does it sit within primary care and what we would expect GPs to do and to prescribe, and do we consider primary care as the best place for these medicines to be prescribed? Okay. And there are examples of medicines like medicines for ADHD where with support GPs can undertake that long-term prescribing, but it's making sure that GPs are well supported in doing that.
Yeah, and sorry, Philip. So in terms of I'll come back to you. In terms of the GPs, Minister, your letter stated that even if a final version of a protocol with GPs is confirmed, that some GPs may not feel comfortable to prescribe and have stated that they will decline requests for shared care. You went on to say that GPs are responsible for the prescriptions they issue, and the government cannot require GPs to prescribe a specific medicine or agree to participate in a shared care protocol. So again, I can see why you're saying it's not a straightforward, simple solution. Can you elaborate on why do you think, whoever wants to answer this one, why do you think that some GPs would decline requests for shared care? I'd be a minister.
Do you feel confident to answer that?
I can make a start. I think largely, and certainly views that we've had expressed back to the PBAC from some GPs is that they don't feel, particularly those who are in a small practice, don't feel that they will see enough patients and gain enough experience day to day to feel comfortable in prescribing and dealing with queries around medicines for ADHD. And they've suggested perhaps in larger practices where they've got more patients, it may be appropriate to have maybe one or two clinicians in those larger practices who have more experience and have done more training and to oversee prescribing for ADHD.
Can you reflect on that, Minister? Given what we've just heard about the numbers of islanders with ADHD and like the figures comparable to antibiotics, I think you said, so it seems like a fairly common condition. Can you reflect on that?
It's actually difficult to reflect on, I suppose, what, say, private entities, which are the GP surgeries, may well be thinking or feeling. And I think if we do get to a place where we've got shared care arrangements, it's around ensuring that there's clear pathways in place and people know where to go for what help and when, but also that communication is absolutely clear as well. Again, I think that's part of the value of having a specific scrutiny review, because I know you also are getting submissions from GPs, so those submissions and the information that you're gathering will be highly valuable as well in enabling us to assess where there may well be other issues or concerns that perhaps aren't coming through to us through our ongoing dialogue. But I will say the dialogue around this is ongoing, and it is a continuing piece of work. It's certainly not something that is being left alone. It's understood as something that needs to be resolved.
Yeah. And what could government do, given that reluctance, which I think is understandable, that GPs have some reluctance around taking on the shared care? What could government do to perhaps incentivise that or make it easier? Is there training that could be funded, or could there be funding for perhaps a specialist clinic so that some GPs could have that additional expertise? Like, what could be done to make that a more attractive thing for the GPs to do?
I think there's probably all sorts and a mix of all of those things that you've just suggested. But at the end of the day, it is that ongoing piece of work around coming to an agreed shared care pathway that everybody feels comfortable with. And then as part of that agreement, I'm sure that between the GPs and the health service, there will be ongoing work to help make people feel more confident going forward.
Yeah.
If indeed, as Sue said, that is the best pathway to be prescribing those medications.
Yeah. And which of those kind of supportive solutions would you be minded to prioritise?
I would need to refer to experts to advise me on that. It's not something that I think would be a political decision.
Would Mr McManus be one of the experts that you would ask? do you want to give a view on that?
Yeah, I mean, certainly we would expect, as part of any shared care arrangement, for the initiating specialists to be the ones who are providing the education and support and training for GPs. And I know Dr Muller Sedgwick has already offered that, and I think has provided some limited training already. Okay. So we know within the specialists on island that there's a willingness to support GPs in doing this and to take part in education and training.
Okay, that's good to hear. Does anyone have any comment on what perhaps the blockers are then, if there is support being offered? Where are the blockers to that support being actually taken up?
Not quite ready yet, is it? I think it's
Sorry?
the shared care isn't quite...
No, I mean, the shared care arrangements are still in development, and as a collaboration between the specialists and the GPs and PBSE. So then they haven't been agreed and signed off yet. In terms of blockers, I think it's GPs. It's not only just about the education and training. It's about GPs feeling that there's adequate support in general for them to undertake the prescribing and not just being seen as somebody signing the bottom of a prescription.
Okay, thank you. Did you have...
Can I just pursue a little further that question from Deputy Renouf about the costs to community prescribers of issuing? You were saying that there's a 30% differential between costs as done by the hospital as opposed to community prescribers. Do the community prescribers act en bloc in placing their orders, or do they all do it individually?
They all do it individually.
I mean, could this problem be ameliorated if they were to act as a collective and having the benefit of bulk buying?
We're tied in terms of remuneration for community pharmacists. We link into a reimbursement scheme for the UK, for England and Wales, and a pricing system that's operated through England and Wales. So we'd have to effectively set up our own remuneration process, which is quite an undertaking.
Do you want to perhaps just explain about how our prescriptions get priced, because that might be helpful for the panel to understand that, yeah? Because it is a very technical issue which we can't do in Jersey ourselves, yeah?
So each year there's about 2.2 million prescription items that are dispensed in Jersey, and each month those prescriptions are sent off island to Newcastle to be processed by the NHS Business Services Authority, and they have an operation that deals with all prescriptions from across the UK to process them, to capture information about who the prescriber is, who's dispensed it, what the medicine is, what the value of that medicine is, with the end result being how much to reimburse community pharmacists for the products that they dispense and the fees that are associated with that dispensing. That's a service that Jersey has bought into for many years. And it's only because of the specialism of NHS Business Services that we can
I'm sorry,
use
I've
that.
probably been slow.
Yeah.
I haven't quite understood. So the community pharmacists don't buy or acquire from some central source the drugs that they dispense?
They will purchase either directly from manufacturers or through wholesalers who are UK-based wholesalers, so that they'll all have different wholesalers that they'll purchase through. They will purchase at one price, we will reimburse them at another price. And the difference is their profit margin. The system that we use to determine the reimbursement price is based on the system for England and Wales.
Right. So it wouldn't make any difference then to a pharmacist, or would it make any difference?
That's correct. Yeah. There's basically a fixed price per item, which is set by the UK rather than by Jersey, because we don't have the facility or the resources to set our own prices. So we have to use a bigger country to do that. So we're using the UK system. And yes, the chemists will take commercial decisions as to how and when they buy drugs at what price, and the government will always pay a set amount for that drug, however it's cost, how little it's cost the chemist to get it.
So the community pharmacists have an incentive to go to some
They
wholesaler.
can get it at
who is
yes, and there've
selling
been
at a lower price.
not so much nowadays, but there used to be kind of arrangements around the discount that pharmacists were able to achieve themselves. Yeah, so now currently, I think the pharmacist just collects anything that they can make. If they can buy at a better price, they will keep that difference as part of their overall profit margin. And so the whole system is based on the pharmacist being able to do that.
So, I mean, a pharmacist could lose money on an
They could lose, yes, and they will lose money on some special items. They'll buy
Yeah.
something in and they'll go out of date. All sorts of things will happen. Yes, yeah.
I mean, what you're really saying is that everybody buys, the hospital and the pharmacies all buy at the same price, roughly speaking, and the difference in price for the pharmacies is their profit margin.
No, so the hospital buys at a cheaper price.
The hospital does get a cheaper price,
Again,
bulk
Paul can
buying.
explain
Yeah,
that. This is the way the pharmacies...
They have access to UK contracts that community pharmacists don't have access to.
Okay, so there is still a price
There is still
differential
price,
there, but
yeah.
most of the differential is attributed to the fact that you then have to reimburse more than the price to the pharmacies in order that they, okay, thank you.
I'm not sure I've understood why a prescription from a GP couldn't be filled in the hospital and access the kind of cheaper.
So that's to do with the legislation.
No, a prescription from a GP could be filled in the hospital. That's up to the hospital. The hospital wouldn't want to take that cost. There are currently two completely separate systems in Jersey. The hospital pharmacy provides the outlet, if you like, for things which are prescribed in the hospital, and the community pharmacists are paid by the Health Insurance Fund to prescribe HIV items. The community pharmacies will also prescribe private items at a cost to the patient. They'll just agree what the price is. And I think you could take a hospital prescription, I'm looking at Paul to check out if it's right. You take a hospital prescription to a community pharmacy as a private prescription if you wanted to.
Could do, yeah.
It's a legal prescription, if you like. There's a difference between a prescription that's legal and a prescription that's going to get, the cost of it's going to be reimbursed by the person you give it to. Yeah?
I'm just trying to get to the nub of the question.
I'm trying to
there and where
understand what's the cheapest route to in terms of where you should expand the provision.
Even if that was the case and that was done, you'd still then have to have the shared care arrangement in place with the GPs.
Yeah.
So that wouldn't in and of itself resolve an issue.
No,
that-
so I suppose
yeah.
the issue is that there's the shortages, there's the care pathways, which involves the GPs, yeah,
Yes.
and then there's the costs of where you access it. So I guess we're talking about costs at the moment, aren't we?
And then you've also got the funding. So you've got the prescriptions being filled out and completed by the hospitals coming from outside of the HIF.
Yeah.
And then prescriptions that are then filled out by GPs and going to community pharmacies being funded via the HIF.
Yeah.
So that's why I have to work quite closely with the health minister as well. And also ensure that we've also got the children's minister
Yeah.
in the loop as well.
So it would be a greater cost to government, would it, if there was shared care with GPs? Would it increase government's costs?
The overall cost to Jersey, yes. If you moved prescribing out of the hospital into the community, you would well, there'll be a different cost, wouldn't there?
Yeah.
You would reduce the cost on the clinics. You'd increase the cost to the drugs, and you'd bear some of the costs of the patient visiting the GP. So you've got a variety of different things to take account of.
Yeah.
But can I just ask Paul to just clarify whether, because we said that the hospital are able to buy drugs cheaper than the community pharmacy, but I'm assuming that if all GPs just sent their, if you could manage it physically, if all GPs sent their prescriptions into the hospital pharmacy would very quickly be excluded from the kind of the contract which allows it to. You can't use the hospital as kind of a place to get cheap medicines from, can you? Because
No, we
yes,
can't.
you can't.
Remember this.
Probably the most important reason why was we'd then lose the fantastic resource that we've got of high street pharmacies. That, you know, the whole mechanism dispensing is about supporting community pharmacists as the most accessible healthcare professionals. So they are an important part of that supply of medicines, and we wouldn't want to have a system where everything went into the hospital.
It's not just supporting the pharmacists, it's a kind of mutual benefit, isn't it?
Absolutely.
As in, if the pharmacy's closed, then that's not available for people to go and get health advice. Okay,
Yeah.
I understand. It really is very complex, isn't it? I think what we'll need to do is compile a grid almost comparing the different options and, you know, who would bear more of the costs and what the impacts would be. So we might come to you for something in writing to help us compile that for clarity.
Just to give you a little bit more background about the hospital pharmacy, is tiny, is it, compared to community pharmacy?
Yeah.
Okay.
Community pharmacy is what, 2 million prescriptions a year?
Yeah, 2.2 million items.
And the hospital pharmacy will be a few 100,000?
Yeah.
It's a different scale, yeah? So you couldn't, if you tried to put an awful lot more business into hospital pharmacy, that would cause enormous problems with the hospitals. So you basically, you've got what you've got today.
Okay.
It may, and I'll make a suggestion that perhaps the panel might want to go and have a look at the hospital pharmacy as well, because it's very tight space, small facility at the moment as well. So there's a practicality, I think, around what's possible.
And there's the issue of around operating hours as well and access for patients. And you know, high street pharmacies are open on Saturday. They're open early in the morning, late in the afternoon and evening. So it's more accessible for patients. It's closer to where they live.
So ultimately then, I think what I'm gathering is that the shared care, is it inevitable? Is it really the only feasible solution given all of these limitations of the hospital and care at the hospital?
That's what we're working towards, is having that clear shared care pathway that people know where they need to go to access the right help and when. But, you know, we need that for all sorts of things. And those interactions between primary care and secondary care is crucial in a number of areas.
Can I?
Can I just say that the shared care only works then, really, if you devise some method for prescribing the drugs which doesn't involve the hospital. I mean, the cost either has to be paid by the patient himself or herself, or it has to be paid by the HIF.
Shall we just describe what a shared care agreement is? Will be a treatment which is not done, which can't be done wholly by a GP. A GP doesn't have enough expertise or clinical knowledge to do it on their own. So it's always initiated in secondary care. So you're always going to go to a specialist first of all. So you're going to go to secondary care. The secondary care clinician is going to set you up for what you need to do. And if they're happy that you're stable on that treatment, they're then going to share the care with the GP. The GP is going to take over the monitoring of that patient and can continue to prescribe the same drug at the same dose and same frequency, yeah? If the GP, who's got the clinical knowledge to monitor the condition, sees any change in the condition and thinks something might need to be changed in terms of medication, they have to move the patient back into the secondary care because it's the secondary care clinician that has to initiate each form of treatment. Is that right, yeah? So it's shared between the two, but the GP, we talked before about training, whatever, so the GP needs to have the training to be able to monitor the condition, but it's not going to be doing the kind of making a change, yeah? So it'll always be shared between the two. So it's sharing it out. So if something's very stable, the GP can carry on with it, but if there's a change or something's not quite right or whatever, it's to go back. So it's, and just while I'm talking, just very quickly on shared care, so we talked about GPs and small practices. You've got to also remember that with the shared care, unless all the GPs are able to feel confident to do it, there'll be some patients who won't be able to access a shared care agreement and some patients who will be able to access it. And then the last thing you've got to remember in Jersey is that if you sort of share care agreement, when you go to a GP, you're going to pay for that. If you go into a hospital clinic, it's free. So there are lots and lots of complexities to doing that. When we get past the technical issue as to how to do it and how to create the right training and support for the GPs, there are other things to think about as well. It's just quite a complicated situation, unfortunately. I think it's probably why we're not quite there yet, because there's lots and lots of things to think about.
Yes, yeah, we had reflected on that, the cost of GP visits. We had reflected on that. Did that answer your question? Yes. Martin?
Have you been involved in discussions with the Minister for Health specifically about this issue, about the shared pathways and the potential resistance among some GPs to being involved in it?
Yes, I have had conversations with the Health Minister. I continue to have conversations with the Health Minister. We do have regular meetings that are set up to discuss issues such as this, which cross over both of our portfolios. So we're keen to be able to resolve issues. And again, mustn't forget within this mix, we've also got the Children's Minister, because that's where CAMS resides as well. There's definitely the will to want to resolve this. It's known that this is having an effect on a number of people and their quality of life, and I can absolutely understand the frustrations of people who are having difficulty, firstly, in getting their diagnosis, and then secondly, in then being able to get the prescriptions and the medications that they're prescribed. So this definitely this issue hasn't been put away in a drawer. I want to give people the confidence that it is an ongoing piece of work that is being taken seriously.
Can you give any indication about when you might reach decisions around this?
It's difficult because of the complexities around this. There are complex conversations that are ongoing at officer level at all times, and it's something that I'm regularly asked for updates on. But due to the complexities, I think it would be ill-advised for me to try and commit to timeframes at this point in time.
But not this year, maybe next year? It's sort of a rough sense. I mean, at the moment, it's beginning to sound a bit open-ended. I mean, is there a sense of that there is a decision point going to come at some point?
I would hope so. This year's rapidly, we're rapidly approaching the end of this year, so I don't think we'll see a conclusion this year. I would hope that we'll see some movement next year, but perhaps I can provide the panel with ongoing updates at future hearings as well with regard to this. This topic is a priority. It is something that we know we need to get resolved, and it's something that ministers and departments are committed to working together on.
Should we keep going?
Yeah. Keep going. We've covered this one.
Yeah, so you state within your letter that the proposal to move repeat prescribing from secondary care into primary care has not been accompanied by a costed patient pathway, which considers financial and behavioural impact. Is that something that's actually underway?
I'll refer to the officers around the actual practical work that's being done.
It's important to
Or could we start, whose responsibility is it to do that, first of all?
Costed patients pathways, which consider financial and behavioural impact, which was what was mentioned in the letter.
We've done some provisional work around that pathway and the costings of the pathway as part of the submission to PBAC. That would then need to be worked out once we got over we got the support from PBAC. We know that the shortages had been the issue around shortages has been removed and medicines are in good supply. Then PBAC, I think, would then feel confident to support the inclusion of the medicines on the list. The next step would then be about building on the work around the provisional work around the costings and working that up in terms of cost of the pathway, because that's the kind of the wider issue. Putting the medicines onto the list is only kind of one part of the whole jigsaw.
And the behavioural impact, to what were you referring when you referred to behavioural impact? Is that behaviour in terms of patients, more patients seeking treatment? Or?
I think it was the minister referred to that in her letter. So it was the minister's words. Yeah.
Sorry, in the...
It's the reference in the letter towards considering the behavioural impact of putting things onto the costed patient, onto the patient pathway.
And I think
So what sort of behaviour are we talking about?
That's about as what Sue was talking about earlier, about being able to see the right clinician at the right time, and thinking that it would be the GP, perhaps people going to a GP when actually they'd need to go to the specialist instead. So, if people think, I can go to my GP and they won't be able to get their diagnosis there, and they won't be able to get a change in medication there. So it's about understanding as well, and people knowing the right place to go throughout that care pathway. I think Sue actually gave a really good explanation about what that shared care pathway would look like, and it's really important that people understand that, so that behaviours don't change and that people go to the specialist when they need to see the specialist.
Mm-hmm. Okay. And could you clarify whose responsibility is it to create that costed patient pathway?
I think there's multiple responsibilities. We've already discussed around how we've got 3 ministers involved here. We've got at least 3 departments involved here. So I think really there's a collective responsibility across the whole piece for ensuring that what we do into the future is sustainable and provides the right level of care for the community in a sustainable and efficient and effective manner. I don't think that one person can hold the responsibility on this piece.
Understood, yeah. I think given that the responsibility is shared, would you agree that this issue perhaps needs a champion amongst those ministers to actually lead and gather all of those views, given the responsibilities are spread out? And could you be that champion?
I am happy to champion this particular issue, but I think the other ministers involved as well are also acutely aware of the issues as well. I think, and thanks to the Scrutiny panel's request, we have got a specialist on ADHD now also added to the Disability Strategy Advisory Group as well. So that group had an update on this situation at its last meeting. So again, in that group, this issue and other issues related to it are visible as well. So there's all sorts of multifaceted approaches to try and
keep this. So a champion is emerging, is what you're saying. We'll keep looking out. Do you want to add any? Yeah, I think.
We move on.
Okay, great. Okay, thank you. Some further questions on the HIF. In fact, I'm just going to reflect on my question plan because we've jumped around quite a bit. Do you think we've covered that?
Yeah, I think we have, yeah.
Okay, I want to ask a question then about the hospital pharmacy, which we've touched on, and the majority, the majority of patients in Jersey who are diagnosed with ADHD are under the hospital consultant and accessing their medication via the hospital pharmacy. Some of our submissions, in fact, many of the submissions we've had, have noted that the conditions, waiting in the corridor and the opening hours, etc., are not ideal for those who are neurodivergent. Could a discussion be had regarding making accommodations in terms of, has anything been considered about that?
I'm not responsible for the hospital pharmacy, although I have had ongoing conversations with the health minister about what I can do where possible to help alleviate some of the issues at the hospital pharmacy. I think actually those submissions, that's useful from the disability strategy perspective around the area. So actually, if I can, I'll take back that those observations, and obviously that would be something for the health minister as well. But with my chair of the disability advisory group hat on, I will also take that to that group as well, and also to my team that work on disability and inclusion.
Thank you,
so
and
they
I'm
can
sure
feed back to the relevant
and we can
departments.
send the submissions to. We may need to seek some permissions around confidential ones. We could send those to you to send on to that group for consideration as well. Okay, anything else?
I'm interested in the situation. We've had a lot of reports back from people who have saved up a lot of money to go for a private diagnosis and then received the sort of sticker shock afterwards that didn't mean just because they'd got a diagnosis that they were going to get free care. So they were in a private, they'd gone down a private route. And I think we were informed that the purpose of the health insurance fund was for a particular set of purposes, and it would be corrupting of that purpose if it was to be used to subsidise private patients or patients who had chosen a private pathway. In fact, offering a subsidy to individuals who have sufficient means to pay for private consultants will add to Jersey's health inequalities, was the kind of summary of the statement. Do you recognise, though, that in this case, these are people who are not necessarily well off choosing to go for a private pathway? They are doing so out of desperation. They spend all their money on that and then end up in a very difficult position when they realise they have to pay for the medicines or go back into the system to pay for the medicines.
I think this comes down as well to clear communication so that people understand what they should be expecting when going for those private consultations. So I would hope that whoever's providing those private consultations is telling people at the outset before they pay before they pay for that what the outcome's going to be. I would be concerned if people are going and paying for that type of consultation without that information at hand.
Is there anything that obligates those providers to provide that information?
Can I just make a point about the health insurance fund? Because I think you were actually asking us questions outside our kind of remit. So the health insurance fund is set up to support the costs of people visiting general practice, and the health insurance law actually very specifically says that it's got to be a general practice service that's provided, and it can't be something that's a specialist service. So an ADHD specialist would absolutely not be a GP. That would not. That's what we're talking about. We're talking about shared care. The GPs may be kind of like a junior partner in some kind of relationship, but they're absolutely not. Their clinical practice does not extend to ADHD diagnosis to start with. So you couldn't use the health insurance fund to fund somebody visiting a specialist in ADHD or anything else. And then we're also saying that at the minute we don't have the ADHD drugs on the health insurance prescribed list. So there's not really any legal way in which you could use the health insurance fund money to support people seeking an initial diagnosis or getting their initial set of drugs. So I think that's more a question for the health ministers in terms of like what could be done there. Health department do contract out some other things in some other areas, so that that's not unknown. They need to use health department do use external providers for all sorts of things at different times.
Okay.
Do you have any information as to the scale of the number of GPs who might be unwilling to help in a shared pathway?
I don't think, we haven't got a, I think the point was made before about larger practices may be better suited to support it because they could have one or two partners within the practice who would actually deal with, and they would have enough patients to maintain their clinical practice. I think that's a really important point. So I think we talked about 1,500 people in Jersey altogether. So that spread that out across 100 doctors. That's not very many people per person. So you probably need a bigger cohort of patients to look after for it to be worthwhile.
So can I just pick up on one thing there? That 1,500 figure, that's the number of people you currently...
That's what.
So
I wrote that down.
that figures come as estimates both from Dr. Catherine Keep and Dr. Muller Sedgwick, based on the current number of patients they have in their service, how many of those are receiving prescriptions, and what proportion they think would be both eligible for shared care and willing to take it up. And I think they both estimate that something like between 50 and 70% of people who are eligible for shared care would want to take that up. Not everyone will because of the costs involved, etc. But that 1,500 figure is very rough based on those estimates.
Thank you.
Does anybody at a ministerial level have oversight of private providers? I'm not sure whether this is your remit or the health minister.
Of private providers in what sense? In the second,
so
like
private
the specialist
prescribers, I guess. Like what's the oversight, and who are those people accountable
So
to?
my area would be the GPs and the primary care, but I think in this context we're talking about the specialist private providers, which would be that's more the health minister.
The health minister holds the performers lists.
Yeah.
And the health minister is responsible for the medicines law. So you're talking about people who are allowed to be doctors in Jersey, that's the health minister, and drugs that are allowed to be prescribed in Jersey, and that's the health minister as well. So the social administrator has got a kind of subset of those things, if you like, yeah?
Okay. Yeah, it's this diffusion of responsibility
Yes.
again, isn't it? What's the solution to this? Is that, perhaps a...
Well, I think the health minister presented us with his solution last week.
Yeah. What do you think the solution is to this?
I am actively, obviously, working with the health minister to look at how we can unify the health service across primary and secondary care. We do need a service that is able to work kind of proactively all together. I am happy to work as a minister with the health minister, and I'm not somebody that would be putting blockers in the way of us improving services and making them more efficient into the future.
Okay.
That's not really answering the question, if I may say so. The question was, what's your solution?
I think we do need a single unified health service. I'm supportive of the proposals that the health minister's bringing forward.
Would that entail a single minister?
A single minister is not something that I'd be opposed to.
Is that part of the plan, do you know?
It may well be. I think that there's lots of, at that point we get into the politics of things. I think what we need to get right first is the structure and the basics, and then we'll look at then how then that then flows up for political oversight as part of that. That's probably outside the remit of this hearing.
She says very hopefully.
I don't know, Philip, what do you think?
It is.
Interesting though. Okay, thank you. I'm going to ask about social prescribing, because many of our submissions have noted that they would prefer a non-pharmacological prescribing. So rather than medication, they would like to have access to perhaps support groups or talking therapies or online courses. And some of the independent, some of the charities that are established already spoke to us about how they are providing some of those, and some of it's funded, some of it's not currently funded. And we're also aware of the Connect Me social prescribing project, which thank you for providing a briefing on that. It was very interesting. And on the Connect Me, first of all, there's a budget of 325,000 being proposed. Is that funding adequate for the Connect Me generally? And will it assist people with ADHD to access some of these social solutions that they're asking for?
Firstly, I would hope that it will enable people with ADHD to access some of those solutions. I've been impressed by what I've seen. I think I've had a very similar briefing to what was given to the panel, I think just last week. It's not been suggested to me that there's a funding pressure, but of course this is a new pathway as well. Everything seems positive so far, and I look forward to actually getting the first reports on some outcomes from the Connect to Me programme with the social prescribing. But it is very new, literally just launched, and I think a really positive thing.
Yeah. And the social prescribing, it's not just the Connect Me projects, is that right? There's other things.
No, and it is, from what I've seen, and it'd probably be best to have the officer who runs this, but it is a wide and broad database of opportunities that are available. So I'm actually really keen to see how this works in an ongoing practical way as we go forward.
So does your department currently fund or commission any services from any of the third sector organisations for people with ADHD?
I probably need to come back to you with details on that, because there is, I'm just trying to think about the organisations that we fund, and some of them probably do provide services for people with ADHD, but I would like to go back and check on that.
Okay, and is that something that you could look at alongside the care pathway? Well, as part of the care pathway, if we're thinking about pharmaceutical solutions, could you ensure that the social prescribing is considered as part of that, so it's not just a drug-based solution being offered?
I'd certainly be open to looking at that.
And do you think,
of course, I think as well, when it's about providing care, any type of medical care, those aren't, politicians are probably not the people that should be making those decisions. We should be looking to specialists.
But the money will be from your department.
To cough up.
Yes.
But I take your point about supporting non-pharmaceutical interventions as well.
Yeah, so do you believe that it's important that those third sector organisations are sufficiently funded so that they can provide those services to individuals suffering with ADHD?
I do, yes, and how we fund and support the third sector is something that I'm currently looking at as well.
Yeah, and do you agree that any funding solutions should go beyond just a kind of 1 year cycle, but there should be multi-year funding supplied?
Yes, that's something that I'd be prepared to talk with the panel at in more detail, and maybe we could have a private briefing based on some of the work that I've asked officers to do in relation to the third sector as well.
Sure, okay.
I was going to backtrack, so if you've got more on that, I've just got one final question on.
Okay, we'll come back to that one. In terms of the pathways then, what would it actually look like? So if a care pathway did involve social prescribing, what would that look like to a patient?
I think that's quite a technical question that I don't feel qualified to answer, but I don't know if...
It's certainly outside my remit. I do the medicines bit.
So the GPs are going to get, either have or about to get access to the social prescribing kind of network that exists. So if a patient went to a GP, the GP would be able to kind of like show them, I'm not quite sure whether it's directly or indirectly, but certainly kind of give them a good route through to a social prescribing solution. And I'm guessing that, I mean, again, I'm talking out of turn, but I'm guessing the hospital will also be involved in that and have the similar kind of routes through, Yeah, so
it's another area, isn't it, with that shared responsibility. But
it is very new and very fresh, and I would say it's probably going to take people a while to get into the swing of how to use it on a very practical level as well.
You're referring to GPs when you say?
I'm referring to any referrer that's going to be using that particular model, because it is a new thing that is available, and it is around ensuring that it is used and people know that it's there and that it can be used as well.
Sure. Okay. All right. Thank you. We might follow up in writing
Sure.
with some of those questions. Jonathan?
I guess listening to this conversation, which has been very, very interesting, very helpful, it's clear that your primary involvement is through the HIF, obviously. That's where your primary responsibility lies. And there's been a lot of talk about the long-term stability of the HIF. And obviously what we're talking about here is potentially close to £1 million being added to it. What are you thinking about the long-term stability of the HIF and these kind of additional demands on it? Does it worry you? Do you sort of want to examine this a bit further, or what?
Yes, of course. I think that I should look at the HIF very, very seriously and the sustainability of it. I think that it also needs to be looked at within the context of the broader health system and broader health funding as well, because, of course, the HIF deals with kind of that primary care element of things, but everything all works together. So I do think that we do need to look at the HIF in the context of the whole health, I suppose, ecology of the whole health system.
Does that mean you're going to run the HIF down to zero?
No, that doesn't mean I'm going to run the HIF down to zero.
So the HIF is going to be quite severely affected if there is some kind of shared care pathway, isn't it? I mean, with the additional £1 million is not something that is sustainable by the HIF at the moment.
I think, as Sue explained, even with a shared care pathway, it may not be the GPs that are always prescribing. So it's not something. But what I don't want to happen as a result of this hearing is people to be concerned or worried that they wouldn't be getting the care that they need. And I think what we need to do is look at what the most sustainable solutions are to ensure that people get the care that they need. Obviously, the HIF has its role to play, but like I said, it needs to work in conjunction with the rest of the health offering that we have. But what I don't want is people worrying around that because what we will find is a sustainable pathway to provide the care.
Thank you.
Is that a ministerial commitment to fund the whatever outcome comes out of this review of the shared pathways?
I think we all need to work together to ensure that people get the medications that they require, no matter what their condition is. So at the moment, I am committed to ensure that people get the medication that they need.
Thank you. I don't have any other questions.
I want to go back to something that you mentioned about communication, and we were talking about the private providers, and I'm not clear whether there is an obligation on the private providers, but we will ask, I think you mentioned the health minister, we will ask the health minister that. In terms of what government could do to communicate what the current situation is with perhaps what the waiting times are for an assessment and what would happen if people go down the private route. Is that something that government could help with and have a page on their website that actually explains that? Because that's something that has come across in the submissions as well.
I think if that's something that's come across in the submissions, that communication needs to be clearer, then I would certainly suggest I'd be working with the health minister to have a look at what information is there to ensure that we have useful and relevant information so that people know exactly what their options are and exactly what the effect of making choices to go private or otherwise might be.
Thank you.
So I think that again, I think that this review is a really useful review in terms of the complexity of these issues, and I think that that's one of the roles of scrutiny, to pick complex issues such as this and do kind of the type of deep dive that ministers can't always do.
Yeah. Could you possibly have those conversations before Wednesday, even on a surface level, because we would like to have some kind of conclusion between the two ministers when we question the health minister on Wednesday?
Yes, I'm sure I will see the health minister before you see him on Wednesday.
That would be great, thank you. Any final questions? No. Is there anything that anyone would like to add on ADHD prescriptions before we close the hearing? No,
Nothing
Mr.
from me, thank you.
Okay. Okay, well, thank you very much, all of you, for attending. It's been great to have you, and thank you for your expertise. It's been very helpful, and we'll keep